ahead, sir.
Well, good evening, friends. Today our guest speaker is Dr. Dabaja Bothaina from Houston, Texas. She will be lecturing on advances in radiotherapy for hemato-oncologists. This webinar is brought to you by Mumbai Hematology Group. It is supported by Ceylon Labs and it is managed by Perfect Square. I thank Mr. Rajesh Mishra and the team from Ceylon, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, the most importantly, our guest speaker, Dr. Dabaja. All our discussants were themselves eminent hematologists, medical oncologists, or radiation oncologists, not only from India, from over 25 countries across the globe. You participants, I'm thankful to you for sparing your Saturday evening, morning, or afternoon. This is our website, www.mhgindia.com. There's no password. You can visit this website for all our future and past academic activities. Tomorrow morning at Indian Standard Time, 11:30 a.m., UK time 6 a.m., we have Professor Mary Francis speaking to us on diagnostic workflow for hereditary erythrocytosis and thrombocytosis. Interested in this branch of hematology, you're most welcome to log in. Our discussants today are various important personalities. They're all put up here alphabetically. Briefly to introduce them, we have Dr. Abhilasha Sampagar from Belgavi, Dr. Amrita Chakrabarti from Delhi, Dr. Asif Iqbal from Guwahati, Dr. Mona Vijayaran from Lucknow, Dr. Murlidharan from Mumbai, Dr. Nilesh Vasekar from Nashik, Dr. Nishad Dakate from Nagpur, Dr. Pooja Prashant from Delhi, Dr. Prashant Bhatt from Mangaluru, Dr. Ritika Khurana from Mumbai, Dr. Riya Balikar from Nagpur, Dr. Sanjeev from Lucknow, Dr. Smita Kayal from Puducherry, Dr. Suma TL from Bangalore, Dr. Varun Bafna from Kolhapur. And now again briefly to introduce our guest speaker. You have heard her number of times and she was our guest in Mumbai a couple of years ago. She requires no introduction. She has been a wonderful speaker and her control over this subject is phenomenal. We love to hear her every few months and she obliges us. I'm grateful to her. So she is a professor and section chief of hematology, Department of Radiation Oncology at University of Texas, MD Anderson, Director of Research, International Lymphoma Radiation Oncology Group at Houston, Texas. She received her medical doctorate at the Lebanese University. She completed her clinical residencies at the American University of Beirut and the University of Texas MD Anderson Cancer Center. She began her career at MD Anderson following her residency in 2006 and has progressed from assistant professor to professor and now the chief of the hematology section in radiation oncology. Her primary clinical goal is patient care with an emphasis on maintaining and improving cure rate in patients with lymphoma while decreasing the short and long-term side effects of treatment. She is extensively involved in clinical trials to investigate multiple strategies to deliver better treatment options for lymphoma patients with the goal of minimizing long-term side effects on patients treated for mediastinal lymphomas, which remains a great clinical challenge. Today, she will lecture on advances in radiotherapy for hemato-oncologists. I invite her to deliver her talk.
Thank you so much for having me. It's always a pleasure to be among you. Today, I chose to talk about some of the advances, and I chose also to take some of the knowledge that we acquired recently and presented at our national meeting, ASTRO, which actually was ongoing last week. So I wanted you to have a view of how radiation oncologists not only view how to manage, in this case, diffuse large B-cell lymphoma, but rather how we are inviting them and educating them to manage diffuse large B-cell lymphoma. I want to also give you a historic or walk you through the path that we went through as radiation oncologists from the time that we were the main treatment to become consolidation. But specifically, I want the audience today to leave with the following notion that radiation is not only used for cell killing, but rather to enhance the microenvironment so then we can couple it with immunotherapy and with adoptive cellular therapy in the future. So I thought that I will address the use of radiation in diffuse large B-cell lymphoma, going from early stage to advanced to refractory and in the environment of CAR T-cell therapy. The major difference that you're going to see is, and I want to apologize, I'm half sick, so I might sneeze or cough, so bear with me. The point that I'm gonna try to make is how our role has shifted from being heavily weighted in early stage or in consolidation to now trying to bridge patients that are living longer and have many available treatment for them in the environment of immunotherapy and CAR T-cell therapy. So this is how we view the world in an early stage diffuse large B-cell lymphoma and educate our radiation oncologists. We tell them that if you have a low risk diffuse large B-cell lymphoma or an early stage, then the ideal therapy would be for them 3 cycles of R-CHOP plus involved site, which is not involved field the way we know it. And we can depend on the update from the SWOG trial that updated the old trial pre-rituximab with the current trial and still showed that 3 cycles of R-CHOP with ISRT is the way to go. We also believe that if you add 1 more cycle to fit in the criteria of FLIER or in the criteria of LISA, it is not really worth it to avoid the radiation because a careful ISRT is usually safer than the 4th cycle of chemotherapy. And I will go through this data that was published by the EORTC on showing how an additional last cycle of chemotherapy is actually equivalent as if you blasted the heart with 5 gray of radiation. If you have a high-risk diffuse large B-cell lymphoma, either by the bulk or high-risk path or the IPI score, then you can go through 6 cycles of R-CHOP, and it becomes the ISRT a question mark at that time. You can argue to omit the last 2 cycles and add ISRT, or you can argue to still use it in some critical situations where you believe that if there is a relapse in that area, it will be detrimental for the patient's outcome. We have a common consensus that any patient who received dose-adjusted R-epoch not to offer them radiation therapy, learning from the experience of primary mediastinal lymphoma. In the following slides that I'm going to show, I'm not going to go through the studies as much as I'm going to go through what we learned from these studies. So these are, most of you are absolutely aware of the pre-rituximab era studies, from the SWOG to ECOG to the JELA. And what we learned from these studies is that more chemotherapy is not beneficial. And we dropped from 8 cycles to 6 cycles to 3 cycles. Now, the effect of that when we omit radiation has been examined in many national database across the diffuse large B-cell lymphoma research endeavor. And it continuously shows that if you omit radiation, then your outcome would go down. I'm not a big fan of national databases. They lack granularity. You're not sure if the data is entered correctly. But then the evidence points at least that dropping the radiation would not be in the benefit of the patient, and it will invite us to do more analysis or data. This is a data that we published at MD Anderson almost a decade ago. It was retrospective. And what it showed is there is a benefit of radiation in all stages and in all patients who received 6 cycles of R-CHOP. And the benefit was not only in progression-free survival, it was also in overall survival. The MINT trial originally was done to see if rituximab would obviate the role of radiation therapy. And it showed or established that bulk is a continuous variable. And as soon as you hit 7.5 centimeter, then those are the ones that not necessarily they're gonna benefit from rituximab. And then the Recover 60 in elderly came to completely establish a role for radiation, because in both intention to treat and per protocol, there was a benefit of radiation that goes all the way to the overall survival. So before I get into this trial, the theme that I'm trying to paint here is the fact that you could see that there is a sweet point where chemotherapy has done its job, and this is where you need to stop. Because as you are aware, the chemotherapy kills with the log, and there is a point that you're going to reach the minimal residual disease, and everything you give after that, it might be just a pure toxicity without any benefit. And that sweet point, in my mind, is really around 3 to 4 cycles of chemotherapy. And therefore, if you want to get the most benefit from radiation, without the toxicity, obviously, and we're going to talk about that in a bit, then this is where you need to introduce radiation. And that way, you will keep these patients at the maximum benefit and the best therapeutic ratios from both the radiation and the chemotherapy. So in the environment of PET scan that is available to us as an interim PET scan or an end of therapy PET scan, we did show that an interim PET scan that is positive is associated with an inferior outcome. So we took that from our data at MD Anderson, and we showed, if you look at the top panel, that patients with the positive interim PET scan, they actually have an inferior outcome seen here in red. And when you introduce radiation therapy at the end of treatment as a consolidation, these curves actually do collapse. And we went one step further in all patients with a PET negative, but they have a residual CT mass. If you remember from the old-time pre-PET scan, we always used to say partial remission, and we would go after these masses and biopsy them sometimes. And not all the time we really found a disease. But what we found here is that even those who would have a PET negative at the end of therapy, but a residual mass, then they have an inferior outcome. Additionally, if you have a less than 2 centimeter residual mass versus more than 2 centimeter residual mass, they actually do worse. So what we do these days is we look at the end of therapy PET scan and we look at the residual mass. And if it is more than 2 centimeter, but specifically more than 5 centimeter, then we do offer radiation therapy. And I will show you a case later on to illustrate that. So what do we do with the early stage LISA and FLIER? As a radiation oncologist, we have issues with it, which is they gave involved field radiation therapy. The last time I used involved field radiation therapy at MD Anderson was more than 20 years ago. And they gave 40 gray of radiation. And the last time we used 40 gray of radiation was 20 years ago. And now we're moving towards 20 gray in a collaborative prospective study that we're doing among the radiation oncologists internationally. So I think that the stratification of the trial, they chose a very favorable group, which is great. They, whenever the patients achieved a partial remission or they did not fit into the complete remission, they were thrown out. or they were eventually completed with 2 more cycles of R-CHOP. So you can see from all of these trials that I'm going to show that we're playing with a 7 to 10% percentage of patients that you belong to 2 camps of philosophy. The one camp that would say, I'm okay with losing 7%, and if they relapse, I'll salvage them and give them transplant. And another camp will say, no, if I actually send them to the radiation oncologist, treat them carefully with radiation, I could gain that 7%, and they would not eventually end up needing salvage or transplant because it's no small treatment that we're exposing our patients to. So then what we learned as radiation oncologists from that is like we make fun of it because seriously, you're still giving involved field radiation therapy to 40 gray. It's like if you tell me that you're still giving MOP to Hodgkin lymphoma. The flyer is not different for us because it's like you're trying to get to a point where you pick and choose only the very, very favorable and still give them a lower, 4 cycles of chemotherapy. And each cycle of chemotherapy you're giving brings you closer to the toxicity that is a cardiac toxicity. And as I will show you later on, it actually does affect the T cell functionality and the T cell proliferation in case these patients have to deal with relapse in the future, or in this world today with all the viruses that are around us. So we have the same conclusion from the flyer. So what we end up using is the best or closest approach for us to use would be the SWOG update, the 0014, where it showed that 3 cycles plus RT is the way to go for us. Same problem. The involved field radiation therapy was a problem for us because that's a very large field that I will show you the difference between what involved site and what involved field means. And the dose is almost twice or 2.5 the dose that we are using these days. I like the study that was published recently in leukemia lymphoma. It is in the elderly, and it does show that a 6 to 8 cycles of R-CHOP compared to 3 to 4 cycles of R-CHOP is equivalent. And what that tells you that you can really, in these elderly patients, avoid further cycles of chemotherapy and just give them radiation therapy and end up with the same outcome. And I'm sure that many of you would end up in this case scenario quite often in your clinic. So what's the problem with adriamycin? Every single cycle of R-CHOP that you give is a 50 milligram per meter square of anthracycline. There is this data that came that showed how the curve goes up very steeply whenever you switch from less than 250 milligram per meter square of anthracycline to more than 250 milligram per meter square of anthracycline. These has to be taken into consideration whenever we give radiation. Coming back to the study that I wanted to discuss with you, the EORTC group put together all the patients that they treated on many trials. And what they wanted to show is what would be the equivalence in radiation of an additional cycle of ABVD, because it was done in Hodgkin's lymphoma, when you give a full cycle of ABVD and end up with 50 milligram per meter square. And what they showed that every time you give 50 milligram per meter square, as if you are blasting the heart with 5 gray. The significance of the 5 gray, this is what we try to limit the heart dose whenever we're treating radiation. We want a dose of less than 5 gray. In reality, if you look at the most recent update by the UK trial, you want a dose less than 3 gray or even 1 gray if you are familiar with this data. So that's what I use in my clinic, and when you're teaching your either junior faculty or residents to use. I use this pediatric data that showed in a normal population where you never received radiation, this is your risk of heart disease going from congestive heart failure to pericardial disease to valvular disease or myocardial infarction. And if you go up to less than 5 gray, that's where you are. If you are between 5 and 15 gray, which is the green line, then you are a bit higher than the normal population. But then obviously when you are between 15 and 35 or more than 35, then look how steep the curve is. So ideally in 7 to 8% from the time you receive the radiation, you're gonna end up with some sort of a heart disease, specifically if you've received more than 250 milligram per meter square of adriamycin. So the main dose that we try to use in our clinic is the less than 5 gray of radiation, and I'll show you examples to that. If you get to a point that you're exposing the heart to more radiation, then it is not worth it to deliver the radiation in the first place. So this is an example of a primary mediastinal lymphoma that presented to us, and eventually after chemotherapy, they presented for radiation. That's a primary mediastinal lymphoma that received R-CHOP and not those adjusted R-epoch, because if they would have received those adjusted R-epoch, we wouldn't have given them radiation. And if you look at the red lines, which is the full dose of radiation, it is hugging the mediastinum, and it is away from the LAD, which takes off here, and it is away from the left ventricle. And the purple line is the 5 gray. So that's what we try to achieve in most of the time of the cases where our 5 gray will be completely off the heart. So then when you're delivering this treatment, you're really going after the area where the disease used to be and avoiding the area of the heart. Now, what I'm going to show you here is this patient did not only present with a mediastinal mass, they presented with a diaphragmatic mass sitting right there next to the heart. And then you could argue, should I chase it or not? You can chase it if you're willing to do the elaborate work that we've done in this case. And the elaborate end result of our elaborate work is we ended up with a tiny field of radiation separate from that field, only to that diaphragmatic node, that we could still see a residual mass after being PET negative. So at the end of the PET, it actually, you could still see the CT residual mass more than 2 centimeters, and that's why we decided to go after it. So in radiation, we use immobilization devices, and we decided that in this particular case, we're gonna bring the immobilization device that we use for the head and bring it and lift up her breast away from the field so we can expose the node that roughly is in this area. Additionally, we wanted to use a breath hold, because what the breath hold would do is you ask the patient to hold their breath, so then the negative pressure that you introduce into the lung will push the heart down and away from that mass. So if you compare, if you ask them to breathe normally, you can see the mass here and you can see the heart there. If you ask them to hold their breath, very deep inspiration breath hold, then that's where the mass is, and that's where the heart is. And that's how we ended up with this particular treatment. How do you make sure day to day that that's what you're going to be delivering? On daily basis, you have a machine with a dual function where you scan the patient on one side, turn them 180 degree, and treat them. And that's how you can guarantee that you're going to be able to target the area exactly how you intended to. So the key points that we teach our radiation oncologists from this first section is, you want to overcome the flyer and the LISA, and you want to learn to convince your medical oncologist to trade the radiation with the last 2 cycles of chemotherapy, or even the last 1 cycle of chemotherapy, by using this wonderful data from the ERTC. How about if you got already to 4 or 6 cycles of chemotherapy, and then your colleague in medical oncology did not send the patient to you until the last minute? Then radiation could be used for local control benefit, especially in critical areas, a paraspinal mass or a mass in the head and neck area that you don't want it to come back and cause permanent side effects. There is an added benefit to avoid relapse. Yes, the added benefit is only 7%, but the 7% is important to really avoid salvage chemotherapy and transplant. If they received REPOC, you leave them alone. Then when it comes to radiation, we use involved site radiation therapy, as I showed you in the previous case. We use technology, all the technology available to us. Now, because we have computer and we have software that we can build solutions to how to target the area without giving radiation or excess radiation to the organs at risk. There is a very exciting study that we are conducting at the International Lymphoma Radiation Oncology Group with over 15 sites from around the world. And we're trying to drop the dose of radiation from 30 gray to 20 gray. If you remember the earlier studies that I showed you, the dose goes to almost 45 and 55 in some of the old data. So you're talking here about 40% or less of the previously used dose. And at this point, the way we practice, our priority is really to avoid the organs at risk rather than to target the area. In a sense that when you are using your computer software, you put the priority and the weight on avoiding the organs at risk. And then the second priority would be to target the area of interest. Now, I would believe, and you could argue against that the benefit of chemotherapy past the time that you already produced a complete remission is very small. So the last few chemotherapy cycles that you're adding in fear of sending the patient to the radiation oncologist is really associated with an unnecessary toxicity to the heart, to the kidneys, to the bone marrow, with a risk of second malignancy. We've seen many studies showing a risk of second malignancies on those patients that are going to live for a long time. And that's what you're hoping for in these particular cases. So I'm going to touch briefly, what do we mean by involved site radiation therapy? This is the old mental field. Actually, this is a modified mental. So it's actually less generous than what we used to use. And you can see in yellow how you go after the breast in part, the heart, and the lung. We don't use that anymore. This is involved field. Let's say you have the blue, which was the original disease. Then what you're trying to do as a radiation oncologist, or what they tried to do in the past, is to chase the area where they thought that there is microscopic disease. That proven to be a false way of doing things, because specifically when you talk about non-Hodgkin lymphoma, in this case, diffuse large B-cell lymphoma, this is a systemic disease. You can never predict where the next echelon is going to be that is going to be involved. You can never predict when it's going to be the extra lymphatic area that is going to be involved. So therefore, pretending that you can chase the contiguous areas as if it is a Hodgkin is going to be false. Additionally, if you say I'm going to chase the microscopic disease, well, the microscopic disease has been taken care of with chemotherapy. That's the whole point why we gave systemic chemotherapy. So that's why we shifted from an involved field to an involved site, where you just treat where the mass used to sit with a bit of margin, so you wouldn't miss it from day to day, putting the patient on the table. As opposed to giving radiation in solid tumors, we pay attention to the marrow. And that's a foreign idea to most radiation oncologists. Because if you tell a radiation oncologist, I want to treat the area in the pelvis, the first thing is going to come to their mind is the bladder, the bowels, the uterus, the prostate. In our case, it's not that we don't pay attention to these areas, but the dose that we are giving, the most sensitive organ around it is the bone marrow. So therefore, if I have to treat a case like this one, where you see the mass in the pelvis and you contour it as such, and then you end up with a dose of radiation that will hug it and try to completely avoid the bone marrow around it. In an adult, there is around 40% of the marrow that sits in these iliac crest and the sacrum. So that's our priority, and that's what we teach our radiation oncologists to pay attention to. So we talked about a PET negative with a CT residual mass. Let's assume that we're talking about this gentleman, that he had diffuse large B-cell lymphoma, received dose-adjusted R-epoch, actually, and eventually ended up with this large mass residual that was sitting on top of his kidney. It was 6 centimeters, and it had some activity of a Duvel 4, and a biopsy was done. We waited on him, because when you give dose adjusted R-epoch, you want to wait on the patient, since these patients sometimes might normalize. Actually, more than 50% of them might normalize. But unfortunately, he did not normalize. And although we did a biopsy, it came back negative. Not necessarily that we believed that it is negative, but then that's what we ended up with, a residual mass, a Duvel 4, even 9 weeks post-therapy with those adjusted EPA, an interim PET scan that was positive. So we build a case that we're going to give him radiation. You might think this is a very hard area to give radiation to. Indeed, it is, because you have the kidney to avoid, you have the liver to avoid, and you have the spleen to avoid, which is another area that our colleagues in solid tumors are not necessarily keen on avoiding. So would the toxicity outweigh the benefit? Yes, it will, if you give the radiation in a way you blast the kidney, or you don't know how the kidney usually function, or you blast the spleen and end up with a lymphopenia. But in this case, we use all the technology available to us. So if you look at the blue line, which is the full dose of radiation, it is hugging the area where the tumor used to be, because that's how big the tumor used to be. And then when it comes to the kidney, you only got part of the kidney, which is 1/4 of it, and you left the rest intact. This is important in the kidney, because the way kidney functions, even if you completely render that area fibrotic, the rest of the kidney, if it doesn't get radiation, it can still function. To our benefit in this particular case, we did a renal scan, and the function of this kidney was barely 30% versus 70% to the other kidney. So therefore, the 30 of the 30%, you ended up actually compromising only 7% of the kidney. We try to avoid the spleen, because we did a study showing that if you do a radiation and you do not pay attention to the spleen, you end up with a lymphopenia. So all in all, we ended up with an excellent local therapy to this gentleman. And luckily, he is 7 years out and still doing well with no side effects. We quite often deal with mesenteric masses. They're also called hard to treat, but I do not believe so, because as I'm showing you here, the red line is the full dose of radiation therapy, where you also went after the mass, avoiding the kidney with the purple line. You will repeatedly see the 5 gray. That's our beacon of light. We always want a 5 gray or less to all the organs around us. That's not what's used for solid tumors, because they deal with higher doses and they deal with more of a deadly cancer. And their role there is completely different than my role. I have a 7 to 10% at most of a benefit that I'm offering you. So I need to match that with the least toxicity possible. And that's why you see my plan are taking care of everything around it by using the technology, as I said. My colleagues quite often are afraid of dryness of the mouth when we give radiation. With the computer solutions that we have available to us, and IMRT right now, and the expertise of how we plan in radiation oncology, you can see that if I am treating even bilateral neck in this case, you can completely avoid the parotid gland. So this is the 5 gray, which is tailored around the parotid gland, and it basically got nothing. Even the submandibular gland that lays here, you can see how the isodose line of radiation, or the dose of radiation, comes and skirt around it or tailor itself around it to avoid both of them. So I'm gonna move right now to advanced stage. And before I do that, I wanna tell you that this phase 2 study of dose-reduced consolidation radiation therapy that is run by the ILROC has enrolled so far 156 patients. The maximum accrual is gonna be 240, and we are super excited about that. The take-home messages from everything I said is that radiation really could be beneficial. We have proved in many of the studies available to us that we can benefit from radiation, including the Flyer and the LISA. And instead of using 4 cycles, I would invite you to use 3 cycles with involved site radiation therapy. I would think that we have to come to a common understanding that adding 2 more cycles of chemotherapy to avoid radiation should be really abandoned, because you're really adding an unnecessary toxicity in fear of something that has evolved and got better. The radiation should be indicated in critical locations, in bulky disease more than 7.5 centimeter, if your interim PET scan is positive, if your residual mass is more than 2 centimeter, and avoid additional chemotherapy even past 3 cycles of chemo. When you use radiation, you have to use ISRT, and that's something you can discuss with your radiation oncologist. You avoid chasing microscopic disease because chemotherapy already took care of that. You prioritize your organs at risk. 5 gray should be the one that you are using. Quite often, the radiation oncologist would say, well, this is a hard goal to attain. Of course, you will tell your planner that you want the 5 gray. If he comes back with 6, 7 gray, at least you're still happy. But if you tell them I want 10 gray, then that's how you're setting their threshold. As soon as they attain the 10 gray, they're happy. And you use all the available technology to you. This is a term that radiation oncologists would understand it. The cartwheel is when originally the IMRT was developed, we used to do an equal distance beams that will come and wrap around the patient. And then we learned over time that we have to do it in an intelligent way, and you have to use a forward thinking when you're using computer, and not to completely trust these solutions that the computer comes up with it, because you know the patient more than anybody else. The dose to use is 30 gray. It's been more than 30 years that we use more than 30 gray at MD Anderson, and the future might be hiding for us actually 20 gray. These are some examples of the areas that we treat and how mindful we are of the organs around. How about a diffuse large B-cell lymphoma, which is advanced? Sometimes I do use it in bulky disease, and this is a simple example that I'm going to give you, where a patient presented with a neck mass, supraclav mass, and abdominal mass. This is the interim PET scan. You could see that there is a substantial residual disease here, but the rest of the disease in his neck and chest went away. And eventually, at the end of treatment, his Duval score was 4. He had a mass of 6 centimeters. Biopsy was negative. But then I ended up treating only the bulky disease. And the reason I can do that, because I can depend on the Recover 60, as I showed you earlier, because it had all stages to show the benefit, even of 6 cycles of R-CHOP in these cases. How about if your end of therapy PET scan has a Duval of 4 or 5? This is no easy task, to be honest with you. These are cases that has to be discussed extensively in a multidisciplinary fashion. I never take a decision on this one on my own. I always take these cases to discuss it with our medical oncologist. The problem with the Duval 4 or 5 is that when you only look at the radiology report, then you will notice that a Duval 4 is a variable of things, and the Duval 5 is a variable of things. I'll give you 2 examples. Let's say that you have this patient at baseline had this mass here, and then at the end of treatment, supposedly he got a Duval 5 in this area. You could see that you can barely see a corresponding mass to it. And then if you ask for a biopsy, they might come back and say it's next to a major vessel. I'm not sure I can biopsy that. And what if you do the biopsy and it comes back negative? Are you going to believe it? And what if it is positive? Are you going to move and salvage these patients because they prove to you that they are chemorefractory? Or are you going to say, I want to give them radiation because in the past we proved that partial remission could be rescued with a radiation dose? Do I have the answer? No. This is an agony when you have cases like this. To be honest with you, we do it case by case. That's completely different than this Duval score of 5, where you treated the patient. This is at the end of therapy, and the Duval score is 5. This is definitely no radiation. As a matter of fact, we use these cases to examine our residents when they're graduating from radiation therapy. And it will be a deadly mistake if somebody would come and say, chemotherapy did not work and I'm going to give radiation. These are cases that definitely have no role to or no place in radiation oncology. I'm going to switch gear to the stuff that we discussed, as I said, in our national meeting last week. And I'm going to show you where we stand in the refractory cases. And I will tell you that there is a shift in our practice currently when it comes to diffuse large B-cell lymphoma. We do see them at the beginning. We do consolidate some of them, but the main bulk of my practice is really in these refractory cases. Basically, we improved the survival of these cases quite a lot, and therefore they have available to them many options, many chemo, immuno, transplant, and CAR T-cell therapy. So then we now have a different role to play, which I call it beyond the cell killing. So as I will show you in the following few slides, how our role in radiation oncology has completely shifted right now. So let's assume that you have a primary mediastinal lymphoma, got dose adjusted R-epoch, did not respond, got RISE, and now the patient is out of options. Let's say you use Nivo on them, you use brintuximab, they're CD30 positive, but then still you have this big mass here, and then you decided that, okay, I'm going to collect them for CAR T-cell therapy. The first thing I want to tell you is that they come to you to radiation to buy time while you're manufacturing the cells. One should never forget that as a radiation oncologist, still your first rule is do no harm. And what I'm trying to show you here is, if you do not use a breath hold in this case, the mass is hugging the mediastinum in a very close proximity to the coronary vessels and the left ventricle. If you use deep inspiration breath hold, you pull that mass up, you open the lungs, and you pulled it away from the coronary vessels and the left ventricle. So therefore, when you treat this area, you are trying to give the treatment with the least toxicity possible. Moving forward to, I'm gonna go through some notions that I'm sure all of you are aware of. The cancer strategy to avoid the treatment or avoid the being removed from the body is by downregulating the MHC class 1 cells, and eventually it can escape the T-cell mediated responses. So over time, we developed 2 ways to solve the problem. One is you use immunotherapy, because then if cancer can evade the immune system by blocking the immune checkpoint receptors, then that's what you're going to use to come back at it. But then the second way we are using now is to engineer brave T cells. It's like your own soldiers that are not doing such a good job. You take them through a training and then you bring them back to kill the cancer. And it is no surprise that there are many paths to use the T cell mediated immunity that over time we've used, getting it from the tumor, from the peripheral blood, from the cord blood. We're now thinking, instead of only using autologous CAR, we're going to be using allogeneic CAR. And Dr. Zvani in our institution is a leading researcher in the NK CAR, in a sense that from one bag of cord blood, They're thinking of producing enough NK CAR that are agnostic to the graft versus host disease, and giving it to almost 30 or 50 patients. So there is a lot of development in the CAR T cell therapy. And then we need to understand, as radiation oncologists, how is it that we're going to fit in that environment, and how to switch our knowledge and our contribution from the chemotherapy era to the cellular era, and know how to interact and converse with adoptive cell therapy. The reason I'm showing you this is not that I'm sure you're aware of it, but to show you how we foresee it as radiation oncologists, and how complicated it is as to when to interfere during that manufacturing. So in a single case, there are many things that can go wrong. And in that area, we interject as radiation oncologists to keep the patient holding with a mass that is growing. It goes from you're extracting the cells, you might not be able to because maybe the functionality of these cells is not amazing. Maybe the patient has been through a lot of chemotherapy, you couldn't reprogram them, the manufacturing failed, or they didn't multiply, or while you're preparing with the cytoreductive therapy, you couldn't do it. So many things can go wrong, and radiation therapy can intersect, but there is an issue that we need to address here as to when can you safely interfere with radiation, and when can you give radiation while you're going through this cycle of manufacturing, because at some time you do not want to give it really before the apheresis, since you might interfere with the collection. You want to do it after the apheresis, but then what timing do you want to use until the reinfusion of those T cells? How do you affect the microenvironment or the T cell repertoire in a way that it will be beneficial as to when to reinfuse these cells? These questions are not answered right now. This is a young field and we're all learning, and that's what I'm trying to show you here. I think that I'm going to use this to reconvince you with my previous slides as to how to avoid further chemotherapy. And the case that I'm going to make here goes as such. I adopted this from Dr. Seth Vanillabou, my colleague at MD Anderson. So you all know that we use CAR T cell in third line, and compared to the Scholar one, we improved the outcome, and we also had a durable outcome. So that's a major knowledge that came from applying CAR T cell in a third line. During that time, we introduced radiation as a bridging in the clinic. Originally, we introduced it to say that let's buy time until you manufacture those cells, because it could take up to 6 weeks to manufacture them, so the patient would not be suffering from a bulk or a pain of the disease. But then along the way, we learned that radiation can induce an immunogenic cell death. So that's why I said originally beyond the cell killing. As we discussed earlier, the tumor has two ways of avoiding the immune system. It exhausts the T cells, and it uses the T suppressor or the Tregs to their benefit. So therefore, if you want to overcome it, you have to reverse the T cell exhaustion and overcome the immune suppression. This is a slide that I borrowed from my colleague, Dr. Ensel. Coming to where radiation works and the concept of radiotherapy as an immunogenic cell death, those are the very same things that radiation can produce for you, which is activating the CD8 T cells, because once you hit the tumor with radiation, you produce antigen, and these antigen goes to the lymph nodes, to the naive T cells, and then it activates them to recognize the tumor and kill it. And you could see that the do not eat me signal is also affected by radiation, and that's to our benefit. There are few studies that we published in radiation oncology. All of them showed that there is a benefit of radiation in the environment of T cell, and that you give it prior to the infusion of T cells. Some of it from MD Anderson, from my colleague, Dr. Penix, some of it from Memorial Sloan Kettering, and from Moffitt. The study from MD Anderson, and what it showed is the following. We all know that the need for bridging is associated with the worst outcome. But what our study showed when you introduce radiation is, although no bridging is associated with a better outcome than with bridging because of the bulk of the disease, but then when you introduce radiation as part of the bridging, you were able to overcome that worst outcome associated with the bridging. So then, although bridging is a surrogate for inferior outcome, there is a potential role for radiation to overcome it. The tumor burden is very important. Therefore, it makes a case for radiation therapy. This has been shown by most recent studies that your tumor burden is inferior, obviously, both in lymphoma and in leukemia. As you can see here, a low disease burden is associated with a better outcome. This slide that I took from my colleague, Dr. Nelapu, I like it a lot because it can prove to all of us that whenever we use chemotherapy, we have to be super careful and think about the future. So what that shows that cycle after cycle of chemotherapy, the most important cells for a CAR T cell survival in the future, the naive and the central memory, the green bars, look how they slim over time. Same thing with the central memory, and they slim over time, while the terminal effector are growing. Additionally, not only the phenotype is affected, if you try to collect and proliferate these cells, eventually, and cycle after cycle, you would fail to even have more than twofold of these T cells. So what that tells you is, it is not a simple matter when we say, let's give 2 more cycles, talking about our my original or at the beginning of my talk saying, oh, let's give 2 more cycles, because you really mess up that immune system. In the CAR T cell world, what that is being used to make the case to now introduce CAR T cell at an earlier stage, so you would not exhaust your T cell system, and you would be able to create an opportunity for a better outcome on these patients as seen here. And at the same time, you're creating an opportunity to introduce radiation as bridging, because in these cases, you're gonna need to debulk these patients. This is one of the abstracts that was presented last week in our national meeting, and it did gave us a pause about how do we contribute to the side effects from CAR T cell, the CRS and the ICANS. And the conclusion from the authors is that all likelihood, and this is from University of Pennsylvania, all likelihood that we do not necessarily adversely affect the toxicity, but rather we might help to actually decrease it. This group is not foreign to how we see a cytokine release syndrome with CAR T cell and neurotoxicity. We believe that the cytokine release syndrome is just telling us that there is activity. We're going through the right path. It's like your graft versus host disease in the skin in allogeneic, where it tells you, good, maybe we're going to have a good result. The neurotoxicity is a different story. And then if you look at the CRS versus the ICANS, it seems that if you do not have CRS, then you have an inferior outcome. It's like it's telling you that it's not working for you. Additionally, it is a treatable condition, while the ICANS is associated with an inferior outcome. Therefore, radiation as a bridging could maybe decrease the tumor bulk and decrease the possible side effects that you are seeing. And the toxicity from the radiation does not necessarily make it worse, As a matter of fact, it could potentially make it better. And we just need to be, as radiation oncologists, mindful of how we intersect with the toxicity that we're seeing with the CAR T cell. I showed this to my colleagues in radiation oncology just to tell them how complicated the field and how we should not still use the chemotherapy as our compass to figure out how we introduce toxicity, but rather this is a field, the cellular therapy, of a very complicated field where the non-responders versus the responders, as you can see it here, does depend on multiple and complex way of the immune system, from inflammatory cells to chemoattractive to stimulatory to effector cells. And we need to study and learn to know how to better introduce radiation without causing any issues. I also showed this, that as opposed to chemotherapy, where we've learned over half a century how to deal with it, in CAR T cell is a young field where there are many factors that affect the outcome, from the intrinsic CAR T cells to the extrinsic barrier, the Tregs, the necrotic tumor cells, how we collect the CAR T cells. And the take-home messages that I want to leave you with today is that there is a role for radiation, because bulky is associated with the worst outcome in these refractory cases. So you can use radiation in these bulky cases and overcome it. We have to learn about CAR T cell process as radiation oncologists. What are the side effects associated with it? Because we might have a possible contribution not only to response, but also maybe to decrease the toxicity. So in this complicated environment where our colleagues in medical oncology are trying to figure out strategies to overcome the process or moving the field forward, looking at different targets, looking at a different way of manufacturing and overcoming the tumor resistance, I would hope that in the near future, radiation would make it to this scheme, and it will not be with cell killing, but it will be with immunogenic cell death in that area. So that's my hope for the future. And I want to thank you so much. And I'm open for any questions.
Thank you so much. Once again, fantastic lecture. So many new things to learn from. Grateful to you. I will ask the faculty over here, they can open their videos and be ready with the questions. Meanwhile, I'll ask you questions from the audience, and I request audience to put in more questions as well. So we have Dr. Asif Iqbal, who has put up a case. 66-year-old female. She has a bulky, painful DLBCL in the shoulder region, 10/8/7. She received palliative radiotherapy of 10 gray before the chemo. Then she took the 6 cycles of R-miniJOB. Post-treatment, PET still shows residual disease 4 centimeter, and there's a decrease in SUV max from 21.5 to 5.4. So will you deliver further radiotherapy to this residual site?
Yeah. So it is a common practice that sometimes if they have a bulky disease and you want to just relieve the pain before starting chemo, although to be honest with you, I'm sure if you would have started the chemo, you would have ended up with the same results and no need for the radiation. But in this case, I would still give the radiation based on the fact that you have a bulky mass that was more than 7.5 centimeter, and you did not give it a therapeutically sound dose originally. You really use the radiation as if it is an additional regimen to your chemotherapy. It's like R-CHOP-R, which is where you're using it also to help you or give you a hand before the chemotherapy. I would also use it because you have a 4 centimeter residual mass there. I'm not sure what the 5.4 read as a Duval score. If it is a Duval of 4, then that means that the interim PET scan would have been also positive. So if you stack the indications, it will be its bone involvement, and from the Recover 60 skeletal, there is a benefit for radiation in skeletal disease. The second one from the Recover 60 bulky, more than 7.5 centimeter. The third one, I bet you the interim PET scan was positive. The fourth one, the residual CT mass of more than 4 centimeter. So I guess, yes, I would. The second one, the question is 38-year-old female. Is it Hodgkin disease? I hope that I'm reading. Yes. Stage 2A, received 2 cycles of ABBD, then 4 cycles of AVD, 2 years. She is PET CT scan negative. Now in PET scan in follow-up, revealed left external iliac lymph node enlargement, no lesion anywhere in the body, left external iliac lymph node excised and biopsy, immunos revealed Hodgkin relapse. Now, what will be the treatment modality that you would suggest? I'm very concerned about a disease with Hodgkin that, okay, the question for you is, was the disease above the diaphragm? If it was above the diaphragm and the patient relapsed below the diaphragm, that's super weird because Hodgkin is a contiguous disease. Unless this was an LP Hodgkin, then I would understand it. But assume that this is not an LP Hodgkin and it is a Hodgkin that weirdly presented there. I would make sure that it is not a T cell rich disease, because sometimes it might imitate Hodgkin. So go back to your pathologist and make sure that you're not dealing with a T cell rich lymphoma. I would not approach this with radiation whatsoever. This is a salvage with chemo, transplant, whatever you want to do, but definitely no role for radiation unless this is a T cell rich or an LP Hodgkin. Does your recommendation on radiation use apply also to pediatric age? No, it does not. Our pediatric group in the Western Hemisphere, they have their own indications and their own way of handling these kids. I am a big believer that in the pediatric age group, where even the marrow production is completely different than the adult, that they need their own way of handling them, and I have no expertise in that.
Thank you. Till the faculty here thinks of a question, we have collected some questions for you by email. One question is about how do you handle solitary plasma cytomas, and does the site of solitary plasma cytoma of the bone affect your decision making?
So we usually handle it with radiation alone, although, so let me go back and say that solitary plasmacytoma 50 years ago, at least 80% of them would transform into multiple myeloma, not because they were more aggressive, but we did not have the diagnostic abilities to really figure out from the get-go which one is plasmacytoma, which one is not. Now you have PET scan, you have genetic markers, you have immunophenotype. We used to depend on skeletal survey, and now we depend on a better ways to differentiate these. But nevertheless, probably a good 40 to 50% are going to transform into a multiple myeloma. So although we suggest that we want to give them radiation alone, but we are mindful that if somebody would come up with a trial where they would tell us we want to give systemic treatment, especially with the amazing improved in survival with the immunotherapy, I would be on board with that. Until that time, yes, I do treat it with radiation alone. I do believe that myeloma is super sensitive to radiation. There is no need whatsoever to still give the old outdated dose of 55 gray. As a matter of fact, I actually dropped my dose not only to 45 gray, I drop it to 40 gray. And then I only go with a higher dose if the mass is more than 5 centimeters. But having said that, if the mass is more than 5 centimeters, quite often it is in more than one side. And I'm thinking probably this is already a multiple myeloma. And then if I have a doubt that there is a multiple myeloma or it's going to become a multiple myeloma, then I go with a regimen that was developed at Princess Margaret, where I give 35 gray instead of 55 gray in 14 fractions to these areas. If it is in the bone, they have a worse outcome, slightly worse outcome than extramedullary. So if it is in the bone, those are the doses that I said I would use. If it is in the soft tissue, then I might drop my dose further. There is a move in the radiation oncology community that we overtreated everything in the past, like exactly how we did with chemotherapy. Anytime you had a lymphoma, you descended on them with the highest dose of chemo, highest number of cycles, and highest dose and field of radiation. As we move forward now to recognize that there are lymphomas that personally, I don't think they're even cancer. Like multiple lymphoma, I think is more like an infection rather than a cancer. And you whiff at it with a bit of radiation and it would go away and never come back and never kills anyone. So we are learning as we go not to be so stubborn and to really decrease the dose and avoid the toxicity.
Thank you so much. The second part of the question was, depending upon the type of bone involved, is there a change in the policy? Long bone versus pelvic.
Yeah. So if I have a long bone, one, I do not chase the whole bone or marrow as they do in sarcoma, because we need to be aware that multiple myeloma is not like sarcoma where you have to chase it. In the pelvis, I look very carefully to really see where the mass is. Is it truly localized to one bone? Did it cross a joint to another area? And then I would do an MRI to look for the signal in the marrow and see exactly how far it is tracking down. Same thing with the long bone. So for the pelvis, I'm super aware that any area in the pelvis I'm gonna treat to 40 gray or more, this area will stop producing marrow in the future and will dry up, and that's going to be detrimental for when those patients come with a multiple myeloma. So my field would be literally just around that tumor by using a PET scan, a CT scan, and an MRI to make sure that I'm not going to unnecessarily treat an area in the pelvis where we said 40% in the marrow is sitting there. These patients 50% of the time, especially in the pelvis, are going to transform into multiple myeloma, and they really need their marrow for the future. So yes, I'm more careful and thoughtful in my field.
Thank you. Prashant, your question.
Hello, ma'am. It was a nice talk, ma'am. My question is basically regarding ALL, acute lymphoblastic leukemia. Patients who are above 60 years, where I have quite a few patients where I have given ALL BFM 2002 modified regimen with a little bit of dosage modification. Now, do you advocate for everybody cranial RT for these patients, or only if there was a cranial CNS positive, CSF positivity at baseline?
Okay. So for ALL, we take some criteria into account at the beginning. If they are in remission and they are not Philadelphia positive, and they are not FLT3 positive, and they are not mixed lineage, then we leave them alone. And we do not give them anything past the high dose methotrexate that they got and the intrathecal that they got. Assume that either they had, assume they relapsed and they were T cell phenotype, or more than 50,000 white blood cells on presentation, or at some point they had a CSF positivity, because when the blood count is very high at the beginning, there is a chance that they cross into the blood-brain barrier. Then in these cases, we try to advocate for a craniospinal irradiation, especially if they are being prepared prior to allogeneic transplant. We also advocate for craniospinal irradiation if you have no options and the patient has a florid involvement with leukemia, because there is a very sweet point that we need to be aware of. If the patient comes with a CNS disease and you keep giving them intrathecal, then eventually you're going to cause a toxicity from the intrathecal that I think for those of you who were during my talk last time, I did talk about it, where you can produce myelopathy that will imitate CNS involvement, but actually it is a toxicity. So that's why our policy right now, that once you get to around 20-25 of intrathecal methotrexate specifically, then we switch to craniospinal irradiation, whether they're going through transplant or not, just to avoid that they will get through that myelopathy. So the short answer to you is, if you achieved a complete remission, even with risk factors, and you are fine and going on your maintenance, we don't touch it. But if the patient recur, even without CNS disease, but with all the risk factors, specifically Philadelphia positive, and you're going to go through transplant eventually, then we do consider craniospinal irradiation.
Okay, ma'am. So in Philadelphia positive, even if the patient is receiving dasatinib or nilotinib, still craniospinal irradiation is required.
Especially if they're going through transplant. That is correct.
Yes. Okay. Yes, ma'am.
Yeah.
Thank you.
Thank
you. Dr. Ritika, you have a question?
Yes, sir. Thank you, Dr. Dabaja, for an excellent talk. So my question is actually similar to what Dr. Prashant asked. So we had a patient of TALL who was not a he did not have hyperleukocytosis at presentation, but he had a LMN facial nerve palsy at presentation. The MRI brain was normal, CSF was normal. But according to BFM, if there is a cranial nerve palsy, it is supposed to be considered as CNS3 and should receive craniospinal irradiation. So we had a discussion with the RT team, and it was decided to give him prophylactic cranial RT because it was not involving the upper motor neuron. I mean, the MRI brain was normal. So this child actually relapsed in maintenance 4th cycle, again in the the palsy and bone marrow. So what would be your take on that, as in prophylactic versus therapeutic? Do you think a therapeutic cranial RT would have been a better option here?
So you're using BFM, which my theory about BFM, and forgive me if you are a big fan of BFM, that I do not think that the BFM can address the CNS disease well. Specifically, you have a T-cell ALL. We are big fan, as you know, of hyper-CVAD, especially for adults at MD Anderson. Dr. Kantarjian adopted that from the children. And the beauty about hyper-CVAD, that you give high-dose methotrexate that will cross the brain barrier and take care of the CNS disease. If I end up with a BFM like in your case, I would definitely have recommended radiation, but I would have recommended a craniospinal irradiation. And this is based on a study that we published at MD Anderson, where we compared the base of skull, because you talked about a nerve palsy, versus a whole brain, versus a craniospinal. And then we showed that those who received the craniospinal are the one who really got the best outcome. Now, you could argue in that study, they didn't get the best outcome because we gave them the craniospinal, but rather is accumulation of many factors. Those are the patients that are going to do well, or those are the patients that they're responsive to the treatment in the CNS, or those are the one that they did so well that they can endure a transplant. We don't have an answer to this question, but I would think that BFM is notorious for a CNS relapse. So as a radiation oncologist, you end up quite often compensating for the inadequacy of the BFM. Rather, if you would have given hyper-CVAD, maybe you wouldn't have ended up where you ended up.
Probably.
Thank you. Dr.
No
Nilesh,
problem.
Dr. Nilesh, you have a question? Okay.
Yes, sir. Yes, sir.
Yeah.
So, Professor, I just want to ask one thing. Extranodal marginal zone lymphoma, stage 1. Would you like to irradiate or rituximab? We go ahead with single agent rituximab also. So, what is your take
love
on
this
that?
question. So I almost have a career based on the extranodal marginal zone lymphoma. it's so hard to convince, not even medical oncologists. Medical oncologists are easy to convince. It's so hard to convince radiation oncologists that you can treat this disease without descending on it with the highest dose of radiation ever. For many reasons, because they're stubborn, because it's very hard for them to change, because there is a financial benefit in the United States if you keep treating the patient for multiple days, all of this. The result of that we unfortunately ended up wasting our time and publishing in every single site. So in the last week in our Astro meeting, we published our prospective study. Dr. Pinnick presented in the plenary session a prospective study that should change the standard of care for orbital MALT, where we give only 4 gray, 2 treatments, and we have a 90% durable complete remission. We published on salivary glands, where we give 2 treatments and 90%. We are presenting our data on gastric MALT, where we have 85% durable outcome with only 2 treatments. We published on skin MALT or marginal zone, same story. We are looking at brain and lung, same thing. We have something like 40 cases of MALT in the lung, 4 gray, and more than 90% outcome. The point is, I love rituximab, but rituximab is, I wouldn't think is a smart drug, because you're just going after the B cells, and it's kind of a blind drug where you're just dropping all the B cells versus you're giving the low dose of radiation, and it's not a cell killing again. It is really, when you give the low dose radiation, you produce the immunogenic cell death, which means you brings the T regulatory down, you increase the T effectors, and then they come and over time have a smart and a strong immunity to get rid of the MALT. And again, another thing that I always say, for God's sake, if a MALT lymphoma could be treated with antibiotics, why should we even ever consider an immunotherapy or anything else? Because in the past, we published in gastric MALT with the H. pylori positivity that you could achieve a 67% response with only antibiotics. And that's why I called MALT lymphoma not even a cancer, it's a fake cancer.
True. Thank you.
Thank you, Nilesh. Any other question from the faculty here? Otherwise, I'll take a question from the email that we have received. Again, a case scenario. There is a 60-year-old man with high-risk myeloma who has received 4-drug therapy, including Darzalex. After 4 cycles, there was complete remission, but the PET scan showed one area in the pelvic bone which is still positive. They've gone ahead with autologous transplant, and even after autologous transplant, that area remains positive. They did a biopsy, and the biopsy shows that there are plasma cells. Is there a place of radiation to this area?
I think there is. We do treat myeloma patients with radiation. I call myself, or I call the radiation oncologist, with like the plumber. You just fix a problem. You never affect the overall outcome of these patients. You're fixing it if they are having a pending fracture or a nerve compression or a pain. In this case, yes, I do believe there is a role for radiation. You can take care of that area, but I am not under any illusion, and I'm sure you're not under any illusion that this patient is gonna be okay. Probably in 3 to 4 months, the disease is gonna show up somewhere else. So I would give it with the both of us would understand that I'm just fixing the problem where you see it, but definitely I'm not gonna affect neither the overall outcome or the risk of this patient coming back with disease somewhere else.
Thank you. Perfect. Dr. Prashant, your question.
Hello, ma'am. This again one of my patient, 36-year-old gentleman who came with swelling in the base of the tongue, around 3 into 2 centimeter. Biopsy showed ABC type DLBCL, and they had done the diagnosis outside. They had done a PET CT, which showed level 2 cervical nodes on the left side. Other than that, absolutely no disease anywhere in the body. So given 2 cycles of R-CHOP, post 2 cycles of R-CHOP, complete metabolic remission. Now, post 4 cycles of R-CHOP, do you recommend a RT for him?
That's a very good question. So I know it is an ABC, and we've been talking about ABC and the Germinal Center for 40 years, and I still fail to see that there is a recommendation from from anybody on is it truly a problem or not.
Given that it was a small size disease,
it,
should we really RT or just leave him?
Okay, I would leave him alone because I'm afraid if you send him to the radiation oncologist, they might do a Waldeyer's ring or something really big. You gave him the 4 cycles. He other than the ABC, it seems he fits in all the flyer and the LISA trials.
Absolutely. So, yeah. Yes, ma'am.
You leave him alone.
Yes, ma'am. Okay, thank you. Thanks a lot, ma'am.
A couple of questions from the audience. One more question is, can you interpret SUV max to be simulating Deauville score?
Actually, we cannot. In the past, we used the SUV as the knowledge about PET scan actually over time evolved, because the difference between the SUV is that you look at it and you put the cursor in your software and it will give you an SUV. The reason we came up with Deauville is every person is different, and the way they metabolize things is different. The way their liver works is different. The blood pool works is different. So then it was very important to say that you make every patient their own baseline. So then when you're looking at a patient and you get the Deauville, then you say, is it above the mediastinal blood pool? Is it above the equal to the liver blood pool or more than the liver blood pool? So that will give you a real interpretation of how active that area is. I can make an educated guess sometimes, like if I look at an SUV of 8, it will be impossible that this is not a Deauville 5. But if I look at one which is 5, then I don't know, maybe it's a Deauville 5, maybe it's a Deauville 4, or maybe this is a patient that is really having a very bad day or a physiologic activity there. We learned, for example, that people, when they sleep, they bite on their teeth. They end up with an activity in their masticator muscles. We learned that if you've been through a fight with your wife the night before and you do the PET scan, you might end up with bruises all over. So it is a very hard way to really move from an SUV to a Deauville score. Having said that, the only way I use the SUV is I use the Delta SUV. For example, a diffuse large B-cell lymphoma that came to me with an SUV of 40 and the interim PET scan went from 40 to 5, that's an excellent result, because the Delta SUV is really steep. And our colleagues in France did publish a paper and they presented their data in ASH where it shows that the Delta SUV is extremely important. The other question is, in a young patient with a grade 2 follicular lymphoma stage 1 with an 8-centimeter disease in the neck, the radiation oncologist suggested that the disease can safely be incorporated within the field of RT. Should we go ahead? I really think so. An 8-centimeter in the neck is too big, but if it is a grade 2, then one more things that I usually do is not only to depend on the grade by the pathologist, because you know that if you do multiple biopsies, in some areas it might be 1, it might be 2, it might be 3A. So one thing you can do, look at the PET scan in this case and make sure with your nuclear medicine to go with the cursor all over the mass and make sure that there isn't an area in that mass which is more than 13 SUV, because that would suggest that this mass is about to transform. If none of it is more than 13, then you can go ahead and give 24 gray to these. But if there is an area with a high SUV, then be careful for the future, because it might come back with a relapse. Having said that, even if it's going to come back with a relapse, it's just going to declare itself. Not necessarily that if you have a follicular lymphoma and you're going to give them chemotherapy or chemoradiation that you're going to change their outcome. I am a believer of the most recent study that was done by our colleagues in Australia, the TROG study that was published in JCO, showing that you give CVP and an extensive field of radiation, you improve their outcome. I am not a believer of that study. When I first came to MD Anderson as a fellow, it used to be that when you get any stage of follicular lymphoma, you treat them with 1 year of ATT, which is triple alternating chemotherapy, followed by radiation, and we never improved their outcome. So my point is, choose the least toxic treatment at this point and hope for the best. You can never prevent them from coming back if they have to come back. 24 gray. The other question is, in non-Hodgkin lymphoma, diffuse large B-cell lymphoma advanced stage, in case of partial remission with more than one site of residual disease at the end of PET-CT, which lesion should be considered for consolidation radiation? If this is a truly PR, which means partial remission, which means it did not respond to chemo, I would not touch them. I would send them to the medical oncologist to give them more chemotherapy. I would only touch these cases if you tell me that I cannot give any more chemo, the patient is going to hospice, there is nothing I can help. Radiation oncologist has no role whatsoever in cases where there is a partial remission. Obviously, other people might feel differently, but that's why I gave the example originally of the 2 Duvel score of 5. There is one which is small, I'm not sure that there is disease there, and there is the one that it is a frank, really partial remission where I wouldn't touch it. So it is case by case.
Right. Going back to the previous case, that follicular lymphoma single site, sometimes the excision of the lymph node takes away the whole disease. And if you do a PET scan, it is negative after the surgery. Do you do anything more or just wait and watch?
That's a very good question. So we published a paper particularly on this particular question, and we showed that even if you do surgery, when you apply radiation after that to the site where the surgery was done, it is actually beneficial. I can find the paper and send it to you so you can share it with the rest of your team. But we do still go after it and give the 24 gray of radiation.
Okay, full 24 gray. Okay, I was just going to ask whether you give 400 or okay. Thank you.
I would not, because it is still supposedly, it is still definitive and curative.
Makes sense. Yes, absolutely. Any more question from anybody? I don't think we have a question from the audience anymore. Over here, Dr. Mona or anybody else?
Yes, sir. So, Professor, what about the dose of TBI in haploidentical transplant, 2 versus 4 in AML? Your take on that?
Yes. So it's becoming like the stock market in my clinic. So some of them are coming with 2 gray, some of them with 3 gray, some of them with 4 gray. I'm going to give you an educated guess about that. The educated goes like this. 2 gray is the one that was established in the New England Journal of Medicine, that it will reverse your T helper versus T suppressor.
Yeah.
And that's why everybody uses the 2 gray. Now, the 3 and 4 gray, the reason I don't mind it, because in some of the studies that we are doing with Dr. Daver, we were talking with Dr. Agarwal at the beginning about Dr. Daver, it's showing that if you actually use 4-gray, there is a chance that you are priming the immune system to your benefit even more than the 2-gray, especially if you give 4-gray at once.
Okay.
So do I have a preference? I would like to have more information about the 4-gray and study it from a lab perspective or a basic science perspective. But I like more the 2-gray because I have a ground to stand on with the New England Journal of Medicine paper that came about the 2-gray originally.
Yeah. Okay. Thank you so much.
Mm-hmm.
Thank you. I think, is that the last question or anybody else has a question? Okay, so we have no more question. Then Dr. Dabaji, thank you so much for once again being with us despite your sickness, and you really participated.
I'm cured now. I have no problem.
Wonderful.
Really, I need to say something, and I always repeat to my colleagues at MD Anderson that the knowledge of your physicians is amazing. The questions that they ask is absolutely amazing. It's really a pleasure being among you. I always say that, and I want you to know that I sincerely get such a pleasure and honor of being among such interesting, smart, knowledgeable, and caring physicians. It's wonderful.
Thank you so much, and have a wonderful day. Thank you for being with us.
Thank you. Bye-bye.
Thank you, ma'am. Bye-bye.
No problem. Bye-bye.
Thank you.
Bye-bye.